The second part of our assessment focuses on the psychosocial aspect of birth. We need to assess the woman's emotional status. We need to observe how she's interacting with her family, with her baby, her level of independence, her energy level. Is she making eye contact with baby? What are her sleep patterns? And is she comfortable holding the newborn? I think it's important to note that not all women have interacted with newborns before. So it's entirely possible that this is the first time that this woman and potentially, the significant other have ever even held a baby. I also want you guys to remember that anything that could adversely affect the mom's emotional state, like exhaustion, pain, the absence of a support system, having a baby in the NICU, a traumatic birth, all of those things can impact her emotional state and her ability to bond with her baby and the attachment process. So keep that in mind when you're caring for patients. There's lots of reasons that pain control and sleep are important, but knowing that they can impact the attachment process is really important too. So our job is to promote attachment behaviors and intervene if needed. Remember that different cultures may behave differently than what's expected in our own culture. End face position is the term for face to face while holding or feeding the baby for moms. Remember, attachment is a process. Anything that kind of inhibits that process can hinder attachment. Healthcare facilities try to keep that in mind when they are making policies, such as not separating the infant and the parents, not having policies that encourage unwrapping the infant, intensive care environments, things like that. So we try to really do everything we can to support this attachment process. This is another reason that rooming in is encouraged, and why a lot of postpartum mother-baby units have gotten rid of nurseries. Here's just a table of positive and negative attachment behaviors that you guys can review. I want you guys to remember that a lot of mothers feel unprepared, uninformed, and unsupported during the postpartum period. That is what research shows women are reporting after having a baby. A lot of them struggle with physical and emotional issues, infant caregiving, breastfeeding concerns, and lifestyle adjustments. And they're leaving the hospital feeling unprepared and uninformed, unfortunately. So it is our job to use all of the time that we have with them in the hospital, which is actually really short. For a vaginal birth, the typical stay is 24 hours, maybe 48. For a C-section, they might stay up to 72 hours, but even C-section patients go home typically after 48 hours. So during that time, our job is to make sure that they feel prepared, informed, and supported for taking their babies home. While doing that, we also need to aim our interventions at promoting comfort. With that, the first step is figuring out what's causing the discomfort as far as pain management. So we can give Tylenol, ibuprofen. Those are the two main pharmacologic methods that we use for pain relief. Application of cold and heat, so ice packs to the perineum really help with perineal discomfort, and potentially a heat pack to the abdomen for cramping, because after pains are real and they hurt and they feel like contractions sometimes. The more babies your patient has had, the worse her after pains will be, or her cramps. They will get worse during breastfeeding, so definitely encouraging ibuprofen and heat packs to the abdomen. You can also use topical um, anesthetic sprays to the perineum and witch hazel pads. We are going to assist with elimination by encouraging frequent voiding um, and educating on stool softeners. Um, if the patient has difficulty voiding, you can do some interventions to hopefully help encourage that. So pouring warm water over the perineum, turning the water faucet on in the bathroom so she hears the running water, things like that. So assisting with elimination is important. Promoting activity and rest, super important. Um, Adequate sleep is crucial for new moms. So we need to make sure and help set realistic expectations, but also educate on the importance of sleep. It's probably not going to be long periods of sleep, but sleeping when the baby sleeps, basically. We can teach about preventing stress incontinence, so pelvic floor muscle exercises at home after women have had a vaginal birth, assisting her with self-care measures, so discussing the ways to prevent infection, like frequently using or frequently changing perineal pads, hand washing, things like that. Women should shower daily, avoid tub baths for 4 to 6 weeks, and avoid tampons. Nothing in the vagina for 6 weeks is kind of the general rule of thumb. As far as nutrition, the quantity and quality of her breast milk is directly related to her nutritional status. Breastfeeding women should drink at least 2,500 mils of fluid a day. So 2.5 liters of fluids a day for breastfeeding women. The more you drink, the more breast milk you will produce. The American Academy of Pediatrics does recommend breastfeeding for all full-term newborns. However, our job is to educate and support whatever decision our patient makes. Women who should not breastfeed are HIV positive women, women taking certain medications that are not recommended for breastfeeding, women taking street drugs, and also if the baby has a known inborn error of metabolism. All other women should be educated on the benefits of breastfeeding. If there are siblings in the home, we should discuss expectations as far as the siblings' impact by the birth. It is normal for them to have some degree of regression. So that might be bedwetting, that might be thumb sucking, things like that. That is very normal. So educating the mom and the dad on what to expect and just helping as best we can prepare them for introducing this new baby to the siblings. Should teach about postpartum blues. We talked about this last week, but postpartum blues or baby blues are normal, usually peak at 3 to 5 days, should disappear by day 10. If the symptoms don't disappear by 2 weeks, the woman should be encouraged to reach out to her doctor. As we're preparing this family for discharge, we need to make sure that the mom has received the necessary immunizations. If she is rubella non-immune, she will need the MMR. We always need to offer the influenza vaccine if it's during influenza season, and make sure that she has been offered the Tdap or tetanus, diphtheria, and pertussis vaccine. Pertussis is whooping cough, and so all family members should be offered that vaccine to prevent the baby. Women also should avoid pregnancy for at least 28 days after being vaccinated. With rubella, it's 3 months, but really they should not be having intercourse for 6 weeks, so that shouldn't be a problem. If your patient is Rh negative and baby is Rh positive, we need to make sure they get their dose of RhoGAM within 72 hours. Our other job is to make sure that the proper follow-up appointments have been made, or that the patient knows when to make those appointments. Women with an uncomplicated vaginal birth usually don't have an office visit for 4 to 6 weeks after childbirth. C-section, usually it's 2 weeks. Newborns, however, are seen within a few days. So depending on how your hospital or how your unit works, you might be making that first newborn well check appointment for the patient. Typically, that's how it works. We make the appointment for them, so they leave the hospital knowing when they have to bring their baby into the pediatrician. And usually it's about 2 days after discharge.